Hey everyone, I'm Amy Zellmer from Faces of TBI, and welcome to the Brain Health Online Summit Training Series. I am a TBI survivor from a fall on the ice in February of 2014, and myself, along with Dr. Jeremy Schmo from Minnesota Functional Neurology, we saw a need in the brain injury community for more training and education on alternative healthcare methods and modalities for those who are still suffering from the lingering effects of a brain injury. Our goal is to help educate and bring awareness to this invisible injury that affects 2.8 million Americans each year and is the leading cause of death and disability in the world. So each day we will be bringing you 3 to 4 speakers who will share their experience in either working with brain injury patients or their own real-life experience of living with a brain injury. So today I'm here with Dr. David Traster, and Dr. Traster is a chiropractic neurologist and holds a master's degree in sports health science. Dr. Traster has established himself as an international expert on brain health and brain rehabilitation. He is an associate professor of neurology for the Carrick Institute for Graduate Studies. He currently lectures around the world and is employed as a consultant for numerous practitioners in regards to their most complex neurological cases. Dr. Traster is also the owner of South Florida Integrative Health in Miami, Florida, where his clinic specializes in the management of a variety of conditions such as brain injury, neurodevelopmental disorders, neurodegenerative disorders, autoimmune disorders, as well as Lyme's disease and other chronic infections. A large reason for his notoriety has been a result of his clinical success with patients who have suffered from a mild traumatic brain injury. So today we are going to be talking about eye movements, the unsung hero of the diagnosis and treatment of post-concussive syndrome. So welcome to the summit, Dr. Traster. Thank you for being here.
Thank you so much for having me. I really appreciate it.
We're very excited to hear what you have to say. And I've probably mentioned this in some of the other videos before now, but you know, my own experience dealing with the eye troubles after my brain injury. So I'm very excited to hear what you have to say today.
Absolutely. I'm excited.
I'll kind of let you jump in.
Okay. Well, I'm excited to share with what you guys are doing because I really think it's really important to spread awareness and education on concussion, because the reality is we know a lot more today than we did last year, but there's still a lot we need to know. So there's still a lot more we need to know. And as a clinician and as a patient, we can't be stuck in a model where we're stuck to the research today without knowing everything. As clinicians, we really need to understand function, appropriate function, abnormal function, because when we look at concussions, there's a few things that are problematic. There are millions of concussions every year around the world, and every concussion is different and unique. So that presents a challenge, because if you accept the fact that every concussion is unique, whether it's the mechanism, whether it's predisposing factors, whether there was an infection before you got hit, whether you have diabetes, whether you have hypertension, things before the concussion, then you have to accept the fact that every evaluation of anyone who's been concussed needs to be unique and individualized, and every protocol for management plan needs to be unique to that person's concussion. So that puts us already in a little bit different model as the traditional healthcare model, because traditional healthcare looks more at protocols. Patient has X, you do these, you get reimbursed for these, and you can't do anything else or you're not going to get reimbursed. And that's troublesome for a patient who has a mixed bag of symptoms. And we really, at a concussion, we know the cause. The cause is an injury, but we're still treating it as symptomatic relief. So what I'm hoping to do today is talk a little about concussions, talk about why we look at eye movements, and present a few cases of where eye movements really made the difference in somebody's life. And what I'm going to do my best is understand that this can get really complicated very quickly. So I'm going to do my best to speak at the most common language, understanding there might be times I stretch things a little bit to make an analogy to help people understand it a little better without using terms like the nucleus prepositus hypoglossi or the interstitial nucleus accueil. That's not going to be beneficial to help people understand what's really going on in the big picture. So that's what I'd like to do today for you guys, if you're interested.
Absolutely.
So we talked about the problem is every concussion is unique, so we need a unique management and you need unique evaluation. One of the problems in the past has been this wait and rest attitude. Mm-hmm. We know one of the biggest factors of long-term disability after any injury or illness is bed rest. So no matter what happens to you, if you just sit and wait and lie in bed, the probability of you having a long-term disability skyrockets. And that's problematic because when you look at somebody in concussion, the acute care, we do need to rest. Everyone in the world is on the same page, but the question becomes, when do you get people out of the dark room?
Right.
When do you start doing some rehab, some graded exercise? And that's the gray area we're in now. I think now compared to maybe 3 years ago, there's a lot more people doing active rehab for patients. Where in the past, it's been wait. The second your symptoms are gone, reintroduce normal life, and the second your symptoms go back in the dark room. Mm-hmm. So now we're moving toward a more active rehab protocol for concussions. And now once we're here, the question is going to be, what is the right protocol? What is the right rehab? And I sent you guys, I'm giving away a free, I think it's about 70 slides PowerPoint, that everything I say in this lecture, the references, the research is in that PowerPoint. So every slide of that PowerPoint is referenced, every information has an article to it. So everything I'm telling you is all referenced. There's nothing I'm going to tell you that's my own opinion. Having said that, I gave it to you so I don't have to sit here and read journal articles to you. So if you're interested in what I say, get the PowerPoint. It's free. And you can look at what I'm talking about and where this information came from. And it's all medical journals. So when we look at concussions, something really important is we need to do imaging. We need to make sure there's not a brain bleed. We need to make sure there aren't these life-threatening things right away. Having said that, a big problem in concussion is your MRIs and CTs for a lot of people with mild traumatic brain injuries are normal.
Right.
And that puts us in a paradox because without imaging it and seeing it, how can we prove it or reimburse therapy for it? And that puts a problem because we now have something, diffuse tensor imaging. I mean, it's not now, we've had it. And so we know diffuse tensor imaging looks at these tracks, these wires in the brain. And we know concussion, if you think about a concussion, an analogy I borrow from Dr. Carrick, who's one of my mentors, is if you take a wet towel and you wring a wet towel, it's the middle of that towel that gets drained the most. So when you look at concussion, when you look at mild traumatic brain injury, assuming there's no coup, counter coup, there's no brain bleed, what you're really looking at is acceleration, deceleration, rotational injury. And this is problematic because we have these wires that can get stretched, and it creates what's called a diffuse axonal injury. So you have these injuries throughout the brain of the communications a lot of times between different areas. And diffuse tensor imaging has been pretty successful at picking that up, but it's very expensive and not many people are doing it. Having said that, when you look at visual following, meaning that look at my thumb and follow with your eyes back and forth, we know that visual following has a very high correlation to diffuse tensor imaging. So there's research in that PowerPoint that shows you the correlation. So some things we like to do is we like to look at eye movements because we know there's a correlation with actual imaging that shows positive effects. When we look at any type of evaluation, the evaluation needs to be unique for each individual person. But what do we like to look at? We like to look at cognitive function. We like to look at vision, eye movements. We like to look at hearing. We like to look at balance. We like to look at walking or gait. And we like to look at coordination activity. And when we look at all these functions, we want to know what is normal and what is abnormal. Because when a patient walks into my clinic and they're quote unquote symptomatic, even if their brain imaging is normal, that doesn't mean their brain function is normal. So that's something that we're going to have to discuss is look at how can we decide what's normal, what's abnormal, what's a normal brain function, what's abnormal brain function, and then how do we treat that when we don't have an image that says the problem is right there. And I think as you probably experienced in your life, that becomes problematic, and that leads to almost a kind of train ride from practitioner to practitioner, which everybody is really intelligent doing their best work, but everybody's going to look at it from their training and their vantage point or their viewpoint. And I think part of why I speak around the world on eye movements is I think it's significant. I think the research shows it's significant. And I don't think the research showing the significance has been translated as well into clinical practice yet. So that's why I wanted to talk to you today about why do we look at eye movements. I'm going to show you 4 cases of why it was significant and hope that people can start understanding that it's important to look at the eyes, and practitioners, if we're watching, it's important to understand maybe a little more of how to look at the eyes, because most basic education looks at eye movements from an eye muscle perspective, and they're really looking at, do you have a weakness of this eye, a weakness of this eye, and that's really important, and it's really important for things like stroke, tumors, and concussion. But the fact is, those eye muscle weaknesses are more associated with strokes and tumors unless you had a pretty bad fracture. What we look at is what happens in the brain before it reaches the nerve. How does the brain coordinate activity to allow you to move your eyes? And that's what I want to talk about today, because we know based on the research, 90% of people who have a concussion have eye movement problems. 90%, the research says, have ocular motor dysfunction. I mean, that's a staggering percentage. And we also know that there's certain research that shows when they actually look at imaging and activity in the actual nuclei, kind of the house where the eye movements live, or the eye muscles live, half of the people have abnormal firing in those nuclei. And that's just off the research. So if 90% of people have something abnormal with them, in which imaging is normal, to me, that's significant as an avenue to research, to try to help people understand, maybe even at an educational level, why they have their symptoms, what is going on, why, although maybe it's in their head and their brain, why this might not be a psychological component, that there's something real and objective being the cause of their symptoms. And then we'll take it a step further of how we can use different rehab protocols, which you've experienced, to actually do things to fix these eye movements. And when these eye movements get changed, people's lives get changed, and it's very significant.
You know, and I'm just going to kind of interject with my experience. I kept telling everybody my eyes weren't okay. Like, my vision was fine, but like, I'm left eye dominant, and my left eye just felt funny. I couldn't really explain what was wrong with it. And my eye doctor, she tried so hard to try and help me, because she's known for like 15 years. She finally referred me to a neuro-ophthalmologist. And as you were saying, they're just looking at the structure of the eye, and is it damaged, is there anything impaired? And my eye was completely healthy. So fine. I'm not fine. And it took me 2.5 years to find Dr. Schmo. So, that's why I'm so passionate about doing that stuff, because if I can help someone else find that right doctor sooner.
I completely agree, because I think, again, it's not to belittle anybody else. Everybody has an important job. And I'm in the same case. I had a 9-year health history myself. And the reason I got into healthcare was I said, if I could have just found the right doctor, even 2 years, let alone 6 months, how much different would my life would have been instead of waiting 9 years? And so that's part of the reason. I love my job as a clinician. I love treating patients. I enjoy teaching, but I love being in the clinic with patients. And the reason I go and I teach and I travel is really because I'm in this profession to help other people. And it's not just people in my clinic. It's people in Europe, in Asia, in Australia, and Canada, and other places I've lectured at, because it's just as important for their clinic to see the same amount of results as my clinic. It's not I'm better than you. It's how can we make everybody better for the benefit of patients, and that's what I think is really important. And that's why I think it's important what you guys are doing, because somehow there hasn't been one of these big summits yet for concussion. Right. For everything else, I don't know. Every day I see a new one for all these random diseases, which are important. But again, concussion is so in the forefront of our society. And yet it's really important. I'm really thankful that you guys are doing this, because I think it's a really good service for people.
Thank you.
So when we look at eye movements, why are eye movements important? Eye movements are important because when you look at the brain, it's a really distributed network in the brain of what coordinates our eyes. And why is that important? It means that it's very sensitive to damage because it's everywhere. You could almost find an area in the brain, or say it differently, when you look at eye movements, they're controlled by almost every area in the brain. So it's very hard to find an area in the brain that doesn't have some role in eye movements, which means that anyone who has an injury to their brain, eye movements could be a viable option to say, hey, is there anything going on? Having said that, you could still have brain issue without eye movement dysfunction. So we know it's not 100%er. But again, with concussion, I'll take 90%, So that's still pretty good. So we look at it for that reason. The other reason we look at the brain and eye movements is we have a lot of different type of eye movements. And we're able to look at different types of eye movements and say, if you understand the generators of the eye movement, to say, hey, this eye movement is good, this eye movement is not as good, the problem must be there. Or to say differently, when you look at imaging, imaging is great to localize an area of dysfunction that shows up on imaging. But when you look at things that aren't shown in imaging, what we need to do is we need to know normal function, test it, and understand when something's abnormal, where in the brain is the cause of that abnormality. So what happens with the eye movements, we have this distributed network without the brain, but each eye movement is a little specific area of the brain, and they share this network where it's almost like if you look at eye movements, it's almost like a workplace. So you have a workplace, you have employees. Everybody's job is for the success of that company, but everybody might just have different roles for that success. Or all of a sudden, you don't get your mail today, well, maybe the mailman didn't show up.
Right.
So all of a sudden you say, well, where's the mailman? Whose responsibility is that? Eye movements isn't so different. We look at a few different things with eye movements and we say, usually, when this goes wrong, the problem is there. When this goes wrong, the problem is there. And it allows us to start localizing areas of the brain, which is really important because if we can't understand where the problem is, we really can't give a good management plan and treatment protocol. We could guess and we could generalize it, but it's not as effective. What we want to be as clinicians is say the problem is there, put a bullseye on there, or maybe there, and then come up with therapy specific to the areas of the brain that's abnormally functioning. Because the research shows pretty clearly, when you look at, let's say someone with a stroke, and we know the stroke is definitely in that one area, a generalized rehab protocol is not as successful as an individual rehab protocol. So it's a different pathology, but it's the same concept that the more specific you can be, the better your outcomes. And to be specific, you need to have a proper evaluation and a proper analysis. So when we look at eye movements, there's a lot of different type of eye movements, but there's really, when I teach, I tell people there's two eye movements. You either look at something or you look at something else. That's it. Those are the two eye movements. Now, within those categories, you have subcategories. So you look at something, I'm looking at you. And now my head could be still, my eyes could be still, and we can call that a visual fixation. And there's certain areas of the brain that allow me to visual fixate. Or to say differently, when you look at your eyes are in the middle of the orbit. Think of your eye muscles. There are about 6 of them on each eye. And that's why we like eye movements, because there's only 6 muscles. They're trapped in the orbit, and they can't really compensate well for each other. When we look at muscles of the spine and the body, it's in multi-planes. Right. You could compensate for them. And, it's very hard. It's more complex. Eye movements are a little more simplistic, and they're stuck in this globe, which makes localizing much, much easier. Does that make sense?
It absolutely does, yeah.
So we like looking at that. So now all of a sudden you have these eye muscles, and let's just let's talk about there's a eye muscle that turns this eye out, and an eye muscle on this side turns this eye in. We have a lateral rectus and a medial rectus, or one eye that pulls out, one eye pulls in. And you should think of these eye muscles like rubber bands or like bungee cords, meaning that if I look out, what's really happening, everyone's going to talk about this muscle contracting. But what's actually happening in the eye muscles is this muscle gets longer. And when it gets longer like a rubber band, it wants to pull the eye back to the middle. So why is this important? It means that anytime your eyes are looking away from midline, that takes brain power. And for people who have concussions, a lot of time that mechanism fails just looking at something when the target is stationary and you're stationary. And we're not even talking about when something's moving in the world or when you're moving. This is just when things are stationary. So that alone, just looking to my right, takes a lot of brain power to keep my eyes from going back to the middle, because that elastic band is stretching, pulling it back to the middle. Does that make sense?
Yeah. When I first went to a vision therapist, one of the tests they had me do was hold the piece of paper and read it.
Yep.
And I was moving my head to read it because, and I didn't even know it. They had to stop me and nope, read it with your eyes, not your head. And I was like, huh? I didn't even know I was doing it. But, using my eyes, it was harder to make my eyes move instead of letting my head move. So that's explaining it. Yeah.
Exactly. Your brain knows that. So even though you might not be aware of that, your brain already understands, hey, vision is so important to my life and my ability to function that if I don't think I can hold my eyes out there without it jerking or moving back and forth and drifting, I'm not going to do it. And your brain automatically knows if I have to look there, I'm going to move my head because I can keep my eyes in the middle and my head can move. And so your brain already, it's a compensation that's going to be beneficial for you, but we want to fix it so you don't need that compensation.
Right.
For some people, we can't rehab their problem because, a stroke or things that might actually kill neurons. There are times we actually give people those compensations. Okay, you can't look to the right, so what we're going to do is teach you how to move your head. So every patient is a little bit managed differently. So when we look at visual fixation, we start with looking at a target that's stationary and our head that's stationary. And then evolutionary, what happened is we start moving as organisms. So originally what happened is the world was stationary and we start moving our head. And this is what's called the vestibular ocular reflex, or VOR, and it allows us to be fixated on a target while we move our head. Because what's funny about the eyes, or it's not funny, but what's interesting, is when you look at the back of the retina, the back of the eye, you have a very tiny area called your fovea. And that very tiny area has all these receptors called your cones. And that gives you a clear vision. That allows you to see clearly. That's when you went to the doctors, they tested your vision, and they said your vision is fine, which is really important to know your vision is fine. The issue is, the second that interest, so our targets of interest here, my fovea should be pointing directly at it. And I have a fovea in my right eye and my left eye, so I think of it as two video cameras. And you have two video cameras that should be pointing directly at the same target. If that fovea is only 2 degrees off the target, 2 degrees is really tiny, 2 degrees off the target, then you're 50% less visual acuity, meaning that your vision has decreased by 50% if your eye is 2 degrees off. So we have this little area in back of our eyes, and our brain's job is to keep the area of target or something of interest within a half a degree on the fovea with both eyes looking at the same thing. Because when one eye is looking at something else, that's when you get blurry vision. That's when you get double vision, when it's really far. Yet the actual vision might be fine. It's that the two cameras are looking somewhere else, if that makes sense.
It does.
And that's a big problem in concussion. You see it all the time. You see people whose eyes were at the same position, and all of a sudden, after concussion, one eye starts drifting out, or feels lazy, or feels weaker, or the eyes start coming together, like I'll show you, they start crossing uncontrollably, and it creates all these symptoms and all these problems with everyday function. So we know we have a VOR, which allows me to move my head and stay looking at a target that's stationary. Based on that function, what evolved is my ability to be stationary and look at a target left and right. We call it a smooth pursuit. So by allowing myself to look at a target who's stationary and move my head, I developed the ability to keep my head stationary and follow a target left and right. And so what that means for us is we want to check both of them. And it means because they grew up together, one was first and then one grew out of it, we could use that therapeutically for rehab. So that's where we use a lot of different head movements and eye movements to fix people's ability to follow a target. We then have what's called an optokinetic response, and that's like, it originally started when people are like, a train is going by you, and you're sitting in front of a train, and this train's flying by. What people didn't realize is their eyes, let's say the train is going to the right, their eyes drift to the right and jerk back left. And we call that nystagmus, and that's normal when you have that visual motion. It's a very global function, but we know when you have a right brain problem, when you have a stroke or lesions in the right brain, this response to the right is decreased to the left. And when it's a left brain problem, the research shows the response to the left is less than the right. So again, we could show individual things saying, okay, how's the right eye movement compared to the left eye movement? There's different areas of the brain that do horizontal eye movements versus vertical eye movements. So we're able to look at different eye movements. How's their VOR? How's their gaze fixation? How's their optokinetic response? How's their pursuit? And then the directionality of it, and have all this different information in our clinic to say, how is this person's brain functioning? We then have, these are all eye movements that keep you looking at something. I said then there are eye movements that have you look at something else. So then we say looking at something else, we have something that's called a saccade. And that means if I'm looking here and I move to here, we have a really fast eye movement that takes us from one target of interest to another target of interest. These could be up to 500 degrees per second, even faster. So these are really fast. They usually last less than 100 milliseconds, which is less than the time to process vision. So you're not really using vision for your accuracy. It's all pre-planned eye movements because it happens faster than vision. Vision takes about 100 milliseconds for you to process it. This happens faster than 100 milliseconds. So it's actually a pre-planned brain activity. And then we look at accuracy. So we look at these fast eye movements, and research has shown people with concussions have problems where when they see a target, it takes them too long to move their eyes to a target. We call that the latency. So we look at different type of eye movements. Different types of saccades. Some saccades come from the front part of our brain and our frontal eye fields. Some saccades come from more in the back part of our brain, or our posterior or parietal eye fields. Some saccades come more in the lower brain, some subcortically. So we look at all these different gap, overlap, all these different types of movements to localize different areas. So point being, we look at all these eye movements, and every eye movement we look at gives us information of different areas of the brain. And then whether we look right or left or up versus down, we get more information because looking to the right is a different part of the brain looking to the left. Looking up and down are different parts of the brain looking left and right. So we have a really nice evaluation of eye movements to look into the brain.
And I just want to ask a question.
Mm-hmm.
So, you've got up, down, left, right. And a person's eye can be impaired just to like one of those directions, right?
Absolutely.
Multiple combinations.
Absolutely. So when you take a look, let's say you have a middle cerebral artery stroke. So let's say on the right side, so half of your right brain isn't doing so well. Okay, now there's other parts that are doing better, but let's just say the right side of your brain isn't doing so well. How would that look clinically? We know if it's a right side brain problem, if you follow a target to the right, it will be impaired compared to following it to the left. So when we start looking at visual following, we know the directionality is more associated with the area of the brain ipsilateral, or the direction it moves and you follow. That side brain has a lot to do with that movement. When we look at these fast eye movements, these saccades, it's the opposite. So when you do a fast eye movement, let's say from left to right, it's actually the left side of the brain that's involved. So it's actually, each eye movement's a little bit different. So a fast saccade to the right is a little more associated with the left brain. A fast saccade to the left is a little more associated with the right brain. And understand that your whole brain is involved. We need to know what's to the right, what's to the left, so it's not really specific to that one area. Having said that, when we look at motor function, your brain processes it, and eventually your brain says, okay, I need to do this movement, and there are specific areas that control the movement. And those are the areas that we look at because, again, we have a right side of the brain, there's certain areas of the brain that fire less. Or to say it differently, if you close your eyes really hard and you have a right brain issue, your eyes are actually going to start drifting opposite. And you'll open up and your eyes will come back to midline. So we have all these different tests, and we're going to look at some eye movements pretty soon to say, here is the eye movement problem. What I'm going to show you is a couple eye movements, and we're going to tell the patient's story and their struggles through their eye movements so you can really understand what they're going through. And for patient disclosure, we're not going to show you the videos of them. I'm not going to disclose too much information, but we're going to show you the eye movement, and we're going to show you the symptoms they're dealing with and some management plans that are able to help them. Does that make sense? And again, so we look at horizontal movements, we look at vertical movements, and we're able to display different things of what's going on in people's brain. And from a diagnostic value, it's priceless. If I could we look at other things too. We don't just look at eye movements, but eye movements tell a very big story. And by looking at the eye movements, we're able to get a lot of information about that patient's brain that without looking at it, we would be really left stranded. So you ready to look at some eyes?
Yeah.
Okay.
I remember doing these tests.
So I'm going to start with one patient. This is a patient we saw a few weeks ago. And every patient we're going to discuss is going to be different. What I want to do is show you 4 different cases and 4 very challenging cases with 4 reasons that are different of why they're challenging. So the first patient 3 years ago had viral meningitis. After the viral meningitis, she had Bell's palsy on the left. She got dizzy. She came with all the symptoms. And then she was in a car accident and then had a concussion after the viral meningitis.
Wow.
So again, this is a tough case because every concussion is unique and individual. But a lot of times we rely on our brain to compensate and deal with our injury and fix itself, quote unquote. And sometimes when you have something before the concussion, it's not as easy to compensate for.
Right.
So when we look at this, I'm going to show you the first two. You might not be able to see so clear, so I'll talk through. This is a symptom score, and this one, don't worry about. What we're really looking at is saying that 2 and under is normal, quote unquote. So it's a symptom score on 2 and lower is normal. When this patient came in, the symptom score was 116. And when the patient left 5 days later, the symptom score was 48.
Wow.
So we see a massive difference despite the fact that we know we have a 3-year post-viral meningitis on top of the concussion. So if we just look really quickly at some of the symptoms, and again, I'm going to read out the reds, which are severe. So if you can't see it, I'm just going to read them out to you. Headache started out as 6. 5 days later, it was a 2. Pressure in the head was a 6, and 5 days later, it was a 2. And this is important for this patient because this patient has idiopathic intracranial hypertension, so she has increased CSF flow, and they don't know why. So there's no tumor, there's nothing blocking the ventricles, but for some reason, the normal pressure is just too high in our skull, which causes that pressure and the headaches. So based on what we did, I'm excited that we were able to take it from a 6 to 2 without draining any fluid in her spine or without draining any cerebral spinal fluid. We look at dizziness, and I'll show you the dizziness and how it correlates to this patient. It was a 6, and it went to a 2. We look at balance problems, went from a 5 to a 2. Sensitivity to light went to a 6 to a 2. Sensitivity to noise went from a 6 to a 1. Feeling slowed down went to a 6 to a 1. Don't feel right is the question. I don't like the fact it says don't feel right, but yeah.
That's how I would, and my eye doesn't feel right.
I prefer it doesn't feel right, but don't feel right, I guess they could do too. So it says don't feel right went from a 6 to a 3. Fatigue or low energy went from a 6 to a 1. Drowsiness went from a 6 to a 3. Trouble falling asleep, a 6 to a 4. And then numbness and tingling went from a 6 to a 1. So again, in 5 days doing specific therapies, again, this doesn't mean this person's cured and we put a photo of her on the wall and we're happy. This is 5 days. This is the beginning of, as you know, a journey to health. Mm-hmm. And so for us, what we're excited about is this patient flew down to come see us for 5 days. And our job was to say, what's the most we could do in 5 days and then not leave you stranded, then give you things to give you tools that you could do on your own and hopefully help you find people more local that can help co-manage the care, knowing that we're here to help you with that. So let's look at the eyes. So this is the eye movements of this patient. And this is, let me just preface this. This is when patient, we put goggles on them. We put them in complete darkness for this test. And what we do is we say, look straight ahead and relax your eyes. So the patient has no vision, and the eyes more or less should just be straight. And you can already see the Bell's palsy, a little facial weakness on one side of the eye versus the other. It's her left, but for you, it might look right because everything's flipped on the camera. So just remember, all these eye movements are really opposite of what she's having based on the camera. So this is her eyes when she should just be looking straight. And what you'll see is for her, it drifts to the left and jerks right, or for you, it's going to look like it drifts right and jerks left.
Yeah.
So you can see.
You know, and I remember this test myself.
Yep, and then now, this is after 5 days of treatment, you can see the eyelids more open, and you can see, it's not perfect yet. We got little drifts here and there, but the drifts aren't big enough. Remember, your eyes like to be in the middle. So what happens is the drifts happen, and eventually your brain says, that's too far, and it jerks back to the middle. So you can see there was no drift that was significant enough to have those eyes jerk back to the middle. So what's this mean for this patient? This patient has these eyes drifting to the left all the time. So what this means for this patient is she feels like she's always rotating to the left. Mm-hmm. So she's feeling like she's rotating to the left, or if it happens with her vision, the world might be looking like it's going to the right. So we start correlating nystagmus, the feeling of dizziness. Is it you or is it the world? And we see these drifts to the left. Again, it's your right, but it's really her left. To her left means that she feels like she's moving to her left, or the world feels like she's moving to her right, or it's moving to its right. The number one complaint this patient had was 10 out of 10 burning all over the patient's skin. So 10 out of 10, last 3 years, 10 out of 10 burning all over the skin, headaches. We have what's called myoclonus, where you have jerking of the body. Mm-hmm. And then you have what's dry heaving, where the patient knew she wasn't going to throw up, but she had this like dry heaving all the time. And they looked at it, and what they said is that typically when you look at this movement, only in dark, you'd say there was a problem, an injury in the vestibular system, and then the brain never compensated for it. Because overall, this should happen. Let's say you cut your right vestibular nerve, or your left vestibular nerve. You're going to start getting this motion. Within 3 to 5 days, your brain should compensate, and it should fix it by itself without this happening. When this doesn't happen, we call it decompensation, or as a lack of compensation, that the brain never compensated. So what we want to do is create compensation to help her with the symptoms. What we noticed on this patient was the frequency of the eye movement jerking was about the same frequency of the jerks of the body and the dry heaving. So we had an honest conversation with this patient. I said, look, I'm pretty confident I can help with your dizziness. I'm pretty confident I can help with your imbalance, because there's obviously, if you feel dizzy, you're imbalanced, because I could correlate that with these eye movements. I have a one-to-one correlation with how you feel with these eye movements. So having said that, it's very hard for me to fix the pain, which is a chief complaint, and any headaches if you constantly feel like you're rotating. It's hard. What I need to do is fix the dizziness first, make you more stable, and let's see what happens. And then from there, we'll go to plan B. Does that make sense?
Yeah.
So what we did.
I had like a head tip, and I remember I'd go in to Jeremy, and he would straighten my head, and I felt like he tipped my head like this. Absolutely,
because there's an imbalance of the way your brain.
My head was trying to compensate for where I was.
Absolutely, we call it an ocular tilt reaction. It's because what happens is you have almost like 2 scales in your inner ear, and each scale detects gravity. And if all of a sudden one scale is a little bit less, your brain actually thinks your head is tilted toward the higher scale, and you're going to compensate and tilt it away. So it's a natural, look, I'm a chiropractic neurologist, my background's in chiropractic, and we're traditionally taught that things are musculoskeletal injuries. But the truth of the matter is it's just not true, because if you have an imbalance in your vestibular system, you're making a good compensation to tilt away. That's helping your brain. Anyone who does musculotherapy to treat the neck without treating the vestibular system might make people significantly worse, or might not be to their benefit. While that might be the right musculoskeletal therapy, it just might be the wrong time.
Yes.
So it's not a bad, because we look at concussions, it's multifactorial, which means you need a multimodal treatment plan. You can't just be a specialist, and this is why it's difficult. You can't be a musculoskeletal specialist. You can't be a vestibular specialist. You can't be a vision specialist. When you deal with concussions, you either need a great team, and everybody plays their part, or you need to be skilled and trained in each individual aspect. So when we look at a patient like this, we say, how can we help her stop the dizziness? And so we do neurofeedback in our office. We were able to measure her brain waves with a QEEG, compare that to normal, and say what parts of her brain are firing too much or too little. We then were able to do vestibular therapy, and we were able to say, you know what? She only has drifts of her eyes to the left. Maybe we shouldn't shake the head both left and right evenly, because she has a natural imbalance. What we might have to do is create an opposite balance, meaning that if her eyes are drifting to the left, with this patient, what if I just move her head to the left and cause a right drift and create an equal drift to the right as she's naturally drifting to the left? And so we do different therapies where we only really turned her head left or up and down. We never turned her head to the right. Mm-hmm. An exam, when you did a reflex, you tapped her knee, and her whole body would jump. It was just so hypersensitive. So we looked at different things as far as electrical stimulation in her body to decrease that excessive hypersensitivity to stimulation of her body, which is really important. And what we're able to do is, we know when you have nystagmus, where your eyes drift one way and go the other way, if you look toward the quick phase, it makes the nystagmus faster, the eye movements faster. So what we did is we trained her during our therapies to look the opposite way. Let's say, what can we do to slow down your eyes? Let's do therapy in that position to have that crossover. And then we also did, some things with breathing, but that was pretty much it. Again, when we look at doing specific therapy, we don't want to throw the whole kitchen sink at people. We want to say, this is specific. So again, what we did was we did neurofeedback. We did some therapies doing left head turns on a dot. We did some therapies doing low-level electric stimulation, which I'm sure you've seen on the body. We have an ARP wave also, and we have an SSCP, which I know you're familiar with both. It's great. So we have both of them, and we do stimulation while the patient's eye is in a certain position. And then we do some balance exercise because now the patient's more stable. We got to train the brain to remember they're stable now. They're so used to being unstable. So now you create some stability, and the brain still thinks you're unstable. So we do different gait and balance and walking exercises to retrain the brain that, hey, things are pretty cool now. You don't have to be so worried about falling over.
Right.
And that was 5 days, and that was the pre and post. I showed you the numbers. And that's it. I mean, now 5 days later, the patient, and we also, from more of a functional medicine, quote unquote, it's a viral meningitis. So we gave 2 supplements from a reputable company that our research has shown to be very powerful antivirals. So now typically with most concussion patients, I might never give them a supplement, but for this patient with a history of a viral meningitis, I thought it was advantageous to use very well-researched supplements that are antiviral in nature because she's never been given anything that's antiviral before. So we also added 2 antiviral supplements to say, hey, let's just treat it multimodal because it makes sense for that patient's history to do so. So that is...
I just wanted to comment on something you said just a little bit ago about the musculoskeletal. And from the beginning of my fall, I have been seeing just a standard chiropractor, and he was working on my whiplash. And I noticed every time I would go in to see him, my dizzy factor would kind of get worse. And when I say dizzy, it was more like that you feel like you're in a fun house.
Yep.
Opposed to spinning. And when I started seeing Jeremy, he's like, we need to stop adjusting you because every time we adjust your neck, it's freaking your eyes out.
Absolutely.
So we stopped adjusting my neck for, probably 4 or 5 weeks.
It makes a big difference. And again, it might be the right therapy at the wrong time.
Right.
Or to say it differently, the way your brain knows where you are in space, every modality you have, let's just take your vision. Your vision is too slow, or response is too slow to keep clear vision while you're walking. Or to say it differently, the number one threat to clear vision is walking. The latency every time you have a footstep is about 7 to 15 milliseconds you need to respond. And the visual system takes almost 100 milliseconds. So every system we have is not perfect. So what our brain has to do is take our vision, our hearing, information from our muscles and joints, information from our inner ear vestibular system, put it all together and say, what's the most perfect picture that I can make to let me know where I am in space with a bunch of imperfect systems? And it computes this picture of your reality based on this information. So if one of this information is incorrect, to your brain, your world is going to be different than the world everybody else sees. And as a concussion patient, it just rings true. How often are you experiencing things in your own world that seem very real, but it's not real to anybody else because it's your brain's getting information that's inaccurate or not enough information to prove what's going on is real. So in your case, what we look at is, we talked about the wet towel that gets drained. The middle gets drained the most. So when you look at the middle of the brain and brainstem, what is that involved with? It's involved with your inner ear vestibular system, which has to do with a lot of balance and coordination. It's involved with your eye movements, which has a lot to do with how you perceive the world in your eyes. And it's very much involved with your autonomic system, your blood flow, your heart rate. And these are 3 really important things that get impacted during a concussion because they're right middle. They're old. They're so ingrained in our nervous system. They're so important to so many functions. So if you have a concussion, and what happens is you have a decrease in vestibular function, vestibular system is so important to tell your brain where your head is in space. So if all of a sudden your brain can't listen to your vestibular system anymore, it's in timeout, it's locked in a dark room, it's not speaking anymore, your brain's got 2 options. It says, well, now I either have to rely on my vision or to know where I am, or my neck. And so what the brain does, those are the 2 compensations. And if it relies too much on your vision, what happens is these are people who become motion sensitive, where things are moving in their world, but the brain doesn't have the inner ear to say, hey, or think of it differently. If I move to the left, the world moves to the right. So if I move to the left, the world moves to the right. The reason I know I move to the left is I have an inner ear and a neck that says my head moving left. If the world just moved right, my brain has to say, did the world move right or did I go left? This is a really tough conversation. And if you don't have the inner ear function, You just lost one of your main ways to say, did my head move? So now all of a sudden, people's vision moves or people's objects in the world move. And if the brain can't go back to say, did my head move, it might think you're moving when you're not. And it could create all these symptoms because they get visual sensitive. On the other end, if you don't have the inner ear to say my brain is here, or inner ear function, say my head is right here, my head is in this space, what it can do is it can tighten your neck, because it says my neck tells me where my head is. So what can happen is it tightens your neck muscles. And that's important to give more feedback into the brain, but that's not so cool for patients sometimes because that could create pain and tightness in their neck, which a lot of times leads them to a chiropractor, a physical therapist, a massage therapist. And without understanding the neck is secondary to the problem, what might happen is you make the neck feel better, but you just gave up the compensation. So although the neck is more range of motion, you now have no idea where your head is. And so now all of a sudden you're off balance and you're dizzy because you just lost the ability to know where you are in space because it was the right therapy, but that therapy shouldn't be done until the vestibular system is intact or the vision is intact. So what we do is we're very specific on the order of therapy. When do we do this? When do we not do that? Because you could do the perfect therapy at the wrong time and it's not perfect.
Yeah. And and I have to say so I'd say working with Jeremy, it was about a week and a half, and I drastic improvement in my eye and my balance, and the dizziness came down. Like I was at like a 9 out of 10 dizzy balance, like 24/7. And we brought it down to like a 2.
Absolutely.
And that cleared up so much energy.
Absolutely.
The brain is trying to understand where you are. It's just sucking all that energy, and then you have nothing left to do anything else.
It's completely fatiguing. Absolutely. What's important with what we do is that this is, even that we talk about this first patient, this is what I promised her. I said, this is what I can promise you, because she's at the end, she doesn't know where else to go. I don't know if I could help this patient. What I promise is I promise I'll do an evaluation and I'll be honest and I'll know very quickly if we can help. Meaning that before the exam is over, the way the nervous system works, as you just described, things happen so quickly if you do the right thing. At the same time, things that go the wrong way so quickly. Right. So I know on my examination, typically, if I can help somebody or not. What I don't know is how much or how quick, but I'll be able to see right away, can I make a difference in this person's life? So right in the examination with this patient, I knew right away there are things we could do that would be beneficial. This patient walked away with 0 out of 10 pain, skin pain. So her chief complaint was 10 out of 10 skin pain. The patient walked away with no skin pain. You could see the eye was more open. The patient for 3 years would smile and the left eye would close.
Yep.
Doesn't have that anymore. The left eye is staying open. There's still an asymmetry, but now the patient can smile with her left eye being open. The dizziness is gone. The dry heaving is not happening anymore. The myoclonus jerks are gone. So the outcome far exceeded my expectations, but my expectations were honest and reasonable. And so it comes down to what are the patient's expectations, what are the doctor's expectations, and being on the same page and hopefully exceeding our expectations. Because our expectations saying in 5 days, 3 years post-viral meningitis with a concussion, I'm happy if we help your dizziness.
All right.
I'm happy to help with stability. And I said, I don't know. Pain is difficult. I don't know if we're going to change your pain. And you look at the skin painting, a lot of times chemical problems have burning skin. And there's a lot of different things where I don't know if what we do is can provide that help. Having said that, we're going to try. And we're going to be honest. We have objective measurements. So you don't have to ever listen. I tell patients all the time, like, I'm from New Jersey. Maybe you shouldn't listen to me. You should. But the fact is, I'm going to measure everything objectively. So you never have to listen to me. We're going to, you've seen it. We're going to videotape things. We're going to have objective measurements with your vision, with your hearing, with your balance, with your coordination, with your brain waves. And we're just going to repeat the test. And it's either going to be better or it's going to get worse or it's going to be the same regardless of how much I want to help you.
Yeah.
And so that was that case. Let's go to case 2. So case 2 is a patient who he came to me at 16 years old. He was a star athlete at 13 when he suffered his first concussion. By the time he was 16, he's had 5 concussions, completely out of athletics, debilitating headaches, could barely get into class. So again, I'm going to show you darkness, no vision. These are the eye movements. Last time we saw the nystagmus where the eyes were drifting with the dizziness. Now we'll take a look at this in darkness with no vision. And so if you can look at the eyes, and you see the eyes are okay, and then boom, it goes crossed.
Oh, wow.
And you can see that, and the eyes get stuck, crossed.
Wow.
You know, and this is really common. When you look at TBI, the most common eye movement problem is this convergence-divergence mechanism. And now this is after just one treatment. This is in the weekend. This is just one treatment. And this is in darkness after one treatment. So you can see it still comes in a tiny, tiny bit. So we're not perfect yet, but after, I just want to show you after one therapy, this is how quickly things change.
That's amazing.
So after one therapy, all of a sudden, the eyes aren't crossing as much anymore. And when you look at these eyes crossing, we call it convergence spasm. The research looks at convergence spasm, and it looks at, it's tough because when you look at research, there's a lot of lesion research, meaning that they kill parts of the brain, and they look at what happens. So a lot of the research is convergence insufficiency, meaning that when the eyes come together, one eye fails to come in. And that's convergence insufficiency. Convergence spasm is excessive activity, which is harder to research. So typically, if you look at convergence spasm, you think it's psychological, it's psychogenic, because there hasn't been a good way to measure it. But I can tell you, we see these all the time in concussions, where the eyes just cross. And what happens is, if you try, if you're sitting at home, you try looking at your nose, and what you're going to try doing, you don't do it. But you'll still feel just naturally a normal person crossing their eyes. It's going to have tension in their upper neck.
Yeah.
And so what happens is when the eyes are constantly trying to cross, the eyes and the neck are hardwired reflexively. So when the eyes are coming in all the time, it's driving neck muscles all the time. And these neck muscles have radiations into the head. We call it greater occipital neuralgia. And it's going to cause head pain and headaches and pain behind the eyes. So it's almost like stabbing between your eyeball. This is all we see with these convergence spasms. We see a lot of different issues. The next patient, I'm going to go deeper into what we see with it. But for this patient, the problem was not being able to exercise. It's a high-level athlete. For 13 to 16, not being able to exercise, not being able to work out, not being able to go into class. It was really tough. And so what we did with this patient, again, we did different eye therapies to try to break it. We did different vestibular therapy to coordinate and converge things from their canals to their otoliths, or really just vestibular rehab therapy, very specific to breaking this convergence. We did different stimulation to muscles while eyes were in a different position again. And again, that was pretty much it.
Yeah.
And what happened in 5 days is funny because day 3, all of a sudden this patient starts smiling, starts joking, and I'd ask about the headaches, I couldn't get an answer. Day 4, the patient's more alive, joking around, very happy. I couldn't get an answer. By day 5, when the patient was leaving, they finally admitted to me, this is the first time in 4 years that there was no headache, and they were afraid to say there was no headache because they thought it would be jinxing it and it would come back.
I get that.
You know, so, and I get that too, but I'd like appropriate feedback. But either way, I get that because who would have thought that, you know, this is a patient who came in and they were at wit's end. The patient couldn't, deep depression, because the patient can't play sports anymore. Fell into kind of a tough lifestyle with some alcohol and drugs, because again, it's just deep depression, trying to figure out, it's a new person. The identity was in soccer as an athlete and completely ripped out of their own control, got stuck, we can't even read. So what happened after 5 days of therapy, they got sent back to where they're from, because again, they flew down for 5 days, began therapy, and the school wouldn't let them get back into gym because they didn't believe somebody get fixed that quickly.
Right.
You know, they want to get back into class. They said, not yet. So they had to wait first to get back into class and then to get back in athletic activity. And what's funny is, it's not funny, but what happened was this patient had an addiction to like fast food. And one of our deals was, hey, if I could help your headache, I used to work in a clinic with this big rotational chair, and I wouldn't spin this person upside down because it wasn't their interest. And I made a deal. I said, if I could get you better in 5 days and your headache's gone, I'll spin you upside down one time. But you have to promise me if I do that, you'll never eat fast food again. So it ended up happening within 3 months. The patient was back playing sports, lost over 100 pounds because they were just healthy enough to move and they didn't have that need for self-comforting, whether it's fast food, whether it's alcohol, drugs, because now they're back living the life they were supposed to live.
That's so awesome.
And again, it was all based on this eye movement. If I didn't see the eyes crossing, then I wouldn't have the plan to try to break it, which directly related to her headaches.
Yeah. That's just
ready for the,
so we're down. We have just about 5 minutes left.
Let's do the next two quick. We'll be quick. So here's the next one. We'll at least do one more. So next one, we look at a red and white optokinetic strip. So this is like the train going by you. This patient's chief complaint was a little over 50 years old, has been in bed for years, saying if we don't get her better in a week, 5 days, they're checking her into a nursing home because she can't take care of herself.
Wow.
Anytime she gets out of bed, anytime she moves, or anytime the world moves, she faints and passes out. And completely debilitating. So we do this red and white strips. It's like, okay, look straight ahead, and it looks like a train's going by, and you'll see what the eyes do. And you're going to see a pre and a post.
Nope.
So this is the pre, and you're going to see this is the stimulation. You're going to see the eyes start crossing right away. So the eyes are closed because eyes start crossing right away. So all of a sudden, any type of movement of her head, which makes the world move, or any movement of the world where her head's stationary, her eyes are going to cross, she's going to faint. And now if you look at it now, when I get to it now, this is going to be, I believe, the post. And it's not perfect, but what you're going to see is that the eyes aren't going to cross anymore.
Wow.
And that's a typical response. It follows and jerks back, just like the train's following the train. So again, so now this patient, after we fix this in 5 days, now they can move their head, or the world can move without their eyes crossing. And without their eyes crossing, they don't have the need to faint. Now this is the up and down. Right away, the ups and downs, eyes cross right away. And when you look at up and down, think about walking. Every time you're walking, your head goes up and down. So how can you walk when anytime visual stimuli goes up and down, your eyes start to cross?
And
it's next to impossible. Driving, everything. Anytime this patient tried to move or something moved on her while watching TV, she'd faint. And now these are the eye movements after. And again, it's not perfect, but you can see no more crossing of the eyes.
That's so awesome.
Super significant with this patient because life-changing.
Life-changing when you get that corrected.
This patient went from not being able to get out of bed to a year later. I only saw her for 1 week that week. A year later, after that week, they went to a trip to Hawaii, and she was the only member of her family that didn't get sick on the helicopter ride.
I love it.
I mean, unbelievable. And I'm going to show you one more case really quick. This is a case where a patient fell at the age of 6 off a cliff and shattered her head 20 different places. So this is significant because on this case, you have imaging is positive. This isn't a mild traumatic brain injury. This is the real deal as far as imaging is positive, staples in the head, certain areas of the brain as far as our technology today are not coming back. So the patient comes in and the patient is spastic on the left. Everything is tight. But the right side isn't great, but it's not so bad. The problem was anytime the patient tried to move the right side of their body, the left side of the body would move by itself. So the patient was spastic with dystonia, then had chorea-4 movement where the arm was moving by itself, and trying to move the good arm made the bad arm move even more. So it put in a really tough spot. And now we look at these pursuits. This is following left and right. Up is to the right, down is to the left. It should be smooth. And you can see in the graph, if you can see it, the graph isn't so smooth and the eyes are jerking around. And what you're going to see is whether it goes to the right or whether it goes to the left, it's about the same problem. It's still not great either way. So we look eyes right and we look eyes left, and we see all these problems. And this following has a lot to do with your parietal lobe, has a lot to do with the maps of where your body is in position. And we talked about eyes to the right is a little more on the right side of the brain. Eyes to the left is a little more on the left side of the brain. So then what we did is we saw her 3 times because she was local. And then we did 3 therapies, had her do it at home. And now all of a sudden, guys to the left start going pretty well. Eyes to the right are better, but still a little jerky. And what that showed in her case is that the eyes to the right, following to the right, is more of the right side of the brain. That the left side of the body started being much better and functional. And we got to the point where she can move her right side of her body without the left side moving. And so again, it showed that 20 years after a significant brain injury, where areas of the brain were literally dead, we were still able to use the functioning, the healthy areas of the brain to compensate and to create a better functionality of life for this patient. So despite, again, 20 years, we had one patient with a viral meningitis with a concussion. We had another patient who was a young athlete with a concussion, who then had some addiction issues. We had another patient with a concussion who's a little bit older. And then we have a patient who's got significant brain trauma that despite the depth of areas of the brain, we still had some good outcomes. And we're still able to use what's healthy in the brain to help out with the areas that might be a little bit damaged.
This stuff is so cool. And I can't thank you enough for sharing this, because I think this will really answer a lot of questions for some people who they'll relate to some of what you're showing with those eyes. And
absolutely,
I know you are offering, if anyone is in South Florida, you are offering a free consultation.
Absolutely.
Have all your information below this video so people can get in touch with you. And if they can't come see you, can they still give you a call and you can help them find someone closer?
Absolutely. We get emails and calls all the time. So again, our job is to help people I always tell people, my job is to help people function better. The reason they come to me is because there's something in their life that's not functioning appropriately. And what our job is to try to figure out, can we figure out why that, do we know what normal is and what abnormal? Can we figure out what the mechanism of that function is that's not working appropriately? And then can we do something to change that? So again, there are people that fly around the world to come see us, but if there's somebody closer to them, that's better. So we all the time help people try to find people close to them who are trained. You know, I teach for the Carrick Institute, Dr. Schmo does. A lot of us teach for this group that trains professionals in all different professions, and that we're hoping that, again, it's not about building our clinic, it's about getting people better. So we're trying to create a network, which I think is important of what you guys are doing, to create awareness. Because you look at these eye movements, again, we don't need the technology to get the work done. The reason we bought the technology was patient education, because once you see it, it's a game changer of how you approach your own care, and it gives you a better understanding of why some of the symptoms you have happen.
I have to interrupt you because our video is going to cut off in a minute.
Yeah, no problem.
So thank you for being here, David.
Thank you.
Everybody for watching. And just remember that you are not alone in brain injury.
Absolutely. Thank you so much.